Hi, Dr. Stephen Allison here. Welcome back. We're on the second phase of red eye, all the causes of a red eye, and these are the more common causes of a red eye and how to approach them. Once you have a couple of pearls, it will be so much easier and you'll be able to handle these problems so much more efficiently. So there's going to be 5 sort of conditions that I'm gonna cover now. Allergy is an important one. Let's talk about allergy and how to treat it. Arc eyes is something that's really so badly treated and so badly diagnosed. Foreign bodies of the eye, how to approach them. Glaucoma, how does it present, and uveitis. So that's the big 5 that we're going to cover in this video. Let's kick off with allergy. Now, as I said, subjective, objective assessment and PAN. SOAP is the way to go, and subjective here is probably the most important part. So you must ask the patient, how is it seasonal? Is it bilateral? Does it come and go? Dogs and cats and so on. In the house, feather duvets, feather pillows, and so on. So you're going to get a really good idea from your history that this is an allergy. Remember, I spoke about the allergic triangle. Allergic triangle means the frontal sinuses right down to the nose. So things that affect your sinuses and affect your nose will also affect your eye because it's right there. Your ethmoidal sinus is right there, your lacrimal sinus is right there, frontal sinus is here, maxillary sinus is here. In fact, 90% of any proptosis that you find will probably be a sinus infection rather than an eye infection. So sinuses and eyes go really close together, and they're all part of that allergic triangle. All right, so a nice little pearl is to hammer this point home. Ask the patient in your subjective, is it a burning sensation or is it a sand sensation? If it's a sand sensation, in other words, it feels gritty, it feels like someone threw sand in his eyes, that's an allergy. If it's a burning sensation, if he says, my eyes feel tired and they're burny, and it's very often late afternoon. In the morning it's okay, but late afternoon it's got a burning sensation. I feel tired, my eyes feel tired, I think it's my glasses, I think it's my computer, I think it's all sorts of things. At the end of the day, that is dry eye. So burning sensation, dry eye, especially that gets worse during the day. Something that's a gritty sensation that's there the whole day and is a little bit seasonal and you wake up with, that is probably an allergy. The other one, as a dark horse, is meibomianitis. In other words, is an inflammation in your meibomian glands. That is par excellence worse in the morning. The guy's eyes are stuck together, and he says he's got to physically open up. He's got to physically open up his lids in the morning because of a small pussy discharge. It's painful, and as the day wears on, it's sort of better. That's meibomianitis. So meibomianitis, early morning, gets better during the day, stuck together. The second one is a burning sensation late afternoon, which is probably dry eye. And then your gritty sensation that is associated with exposure to allergens, or at least is seasonal, is allergic. Remember, when we think about allergy, the eye is no different to any other. The main allergy in the body is my asthma. And remember the 4 S's of asthma that we learned as registrars and as pre-graduates is stimulation, swelling, secretions, spasm. Stimulation, swelling, secretions, and then spasm. All right, now in the eye there's not really spasm, it's more to do with the asthma, but there certainly is always stimulation first, then swelling, then secretions. So when you're treating, you must try and treat all 4 of those, or at least the first 3 of those. So never just treat the allergy with an antihistamine and think that you've treated the patient. That's just not true. Remember the mast cell? The mast cell is floating around, and it has all the mediators of inflammation in it, and it has its receptors, and that mast cell then is hypersensitive to some or other allergen that's coming in. It triggers it, it bursts the mast cell open and sets the histamines free and all the mediators of inflammation, and you get the swelling, the secretions, and the pain, and everything that goes with it, the rubor or tumor functionalizer. The whole inflammatory cascade gets put into action when you have this stimulation. So when treating an allergy is you need to make a diagnosis. Make sure that it is an allergy. You know now how to do it. Good history, gritty sensation, seasonal. In the allergic triangle, probably associated with high fever and sinus problems. That's an allergy. But you can't just treat an allergy with drops or with antihistamine tablets. You've got to go into your history and say, no dogs or cats on the bed, no birds in the house, no feather duvets, no feather pillows that you lie on. You need to stop the stimulation. It's no use just treating the other end. You must treat the initial end. And very often, if you do go into the history, everybody goes, yeah, okay, I now understand, absolutely. And remember, as a dark horse, this is very, very important, is in allergies, two of the things that our body is just not equipped to handle, and that sort of is always there when you talk about allergies, is food, is milk with your lactose intolerance, and gluten, which is your bread. So milk and bread and animal products need to go if you're treating allergy. And then you start your antihistamine treatment and your mast cell stabilization and so on. Okay, so the treatment normally for an allergy is prevention, number one, no stimulation. And you have to give, because there's three things that at play here. You have a mast cell that breaks, so you need to stabilize the mast cell, something like some sodium chromoglycate or anything. So you need to give a preventative medicine. Number two, you need to give an antihistamine. You need to block the histamines that grow. But remember, there's already an inflammatory process on the go, and you need to stop that, because if you can turn his red eyes into whitish eyes that aren't painful anymore very quickly, you're a clever doctor. Even though that's not the treatment. That's really just the end result treatment. The treatment is actually get the dogs and cats off the bed. But at the end of the day, you need to also just give him some short burst of cortisone, of steroids, a short burst of maybe some antibiotics, even if there's a pussy discharge, short course, then give him preventative medicine, sodium chromoglycate with an antihistamine. You can even give oral antihistamines and be in conjunction with your ENT surgeon as far as that's concerned, because it's probably as a result of a larger disease, that the eyes are not in isolation in this case. Right, so that's allergies in a nutshell. Again, primum non nocere, if you haven't made a diagnosis, don't treat. Don't put cortisone in someone's eyes that you don't know what the cause is. It may be an early dendritic ulcer that's making his eyes red, even though he does also have an allergic history. Don't go boshing into the eye with cortisone if you haven't made a proper diagnosis, please. Very, very important. First, do no harm. No treatment is far better than bad treatment. So that's very, very important. Most of these things are self-limiting as well. So if you just wait, they probably go away. So please don't just treat willy-nilly. Don't be emotionally blackmailed into giving treatment just because the guy's eyes are red. Very important. Right, now arc eyes. Let's talk about arc eyes. What is arc eyes? Arc eyes is basically a second-degree burn of the cornea. It's a second-degree burn of the cornea, just like you get a second-degree burn of your skin if you lie in the sun. That comes off of the arc from welding is UV, ultraviolet light, the same stuff that comes from spikes up there. So the sun gives you UV, you lie in the sun, you fall asleep on the beach, you're going to be red, painful, even have some blistering, and the epithelial layer is going to peel off eventually. So that exact process is happening on the cornea, except the cornea is very, very sensitive. The fifth cranial nerve, your trigeminal nerve endings, there's a massive amount of them right under the epithelium of of the cornea, right there. They're sitting there waiting to warn the eye of any foreign thing that comes in, or any problem, or any dust, or anything like that. So what happens now in arc eyes, this guy keeps his eye open while he's welding, or he gets a flash from the side and so on. This burns his eye and in effect kills off the superficial epithelial layer. It kills it off. Now, because it's such a high turnover, it kills it off, and it actually sloughs away in part. It sloughs away. And when it does slough away, you have exposed trigeminal nerve endings. Now, if you have exposed trigeminal nerve endings, it would still be okay if you didn't have a lid that was going every time you blink. So there's your problem with arc eyes. Now, it's normally guys that work with their hands are dirty, they're used to being outside, they're strong, they macho alpha males that get arc eyes. That's the demographic. It's never going to be a program analyst sitting in the basement section of Apple that are going to get arc eyes. So it's going to be a certain type of person. He's going to give a history. Just remember that those guys are used to traumatizing their eyes. We're going to get onto foreign bodies now. So don't be swayed by their history, saying, man, I know this is just arc eyes. Just quickly give me some treatment, please. I know it's arc eyes. I've had it before. It's not a problem. Be careful. There could also be a foreign body, a metal foreign body there that you need to remove. But we'll get onto that now. So first of all, again, make the diagnosis of arc eyes. You don't see any foreign bodies. You don't see any other reason for this guy having this terrible pain in his eyes with tearing. And arc eyes very often, or almost always, is bilateral, where foreign bodies are unilateral. So if he says he's got arc eyes in one eye, he's probably got a foreign body. He's probably not got arc eyes. So don't be swayed by the patient. And these are alpha males. They're bushy, and they tell you, no, man, I know what it is. I get this from the doctor many times. Just give it to me. I'll do it. Don't do that. Don't get pulled into that. Try and make your own diagnosis. So now you've got the superficial burn of the eye. What do you do with superficial burns anywhere in the body? If you have a superficial burn of your forearm, what would you do? Very simply, you would do an occlusive dressing. Occlusive dressing. That's what you would do. You would dress it, you would give some antibiotic, you would clean it properly, you would give some antibiotic, you'll cover it, and you'll keep it closed. Occlusive dressing. That's the treatment of a superficial burn. In other words, you must cover it and keep it covered until it's better. Now, the problem with the skin takes 6 weeks to heal properly. So you need to put your bandage on for 6 weeks and check him every now and again and so on. Now, the eye, fortunately, regenerates that epithelium quickly because it's designed to do that. It's designed to slough off and come on again. So 24 hours later, it's formed a new epithelial layer. So your treatment, in effect, is keeping the eye bandaged for 24 hours. Bottom line. You just keep it bandaged for 24 hours and you've treated your arc eyes. Okay. So it is very little to do with what you put in his eye or not put in his eye or anything other than keeping his eye closed for 24 hours. Bottom line. So how do you treat arc eyes? You don't put milk in his eye. You don't put the chief's urine in his eye. You don't put his urine in the eye. You don't put Aunt Agatha's drops that are in the fridge for something else in his eye. Don't do that because he's got a superficial burn of his eye. The other thing that people, the GPs especially, like putting in is a non-steroidal anti-inflammatory drop. Now, non-steroidal anti-inflammatories, by their very nature, burn a little bit or are a little bit painful. Anybody who's had a Voltaren injection or a non-steroidal injection knows that it burns a little bit, more than a little bit. So this guy's already got exposed trigeminal nerve. Now you're going to put an anti-inflammatory in there. It's going to burn him more, and it's actually going to prevent wound healing. So you've actually done him a disfavor. I think the myth comes from the fact that when someone has a superficial burn or they have a burn from lying in the sun, they give anti-inflammatory rubs to put on. Now that can work when it's in your skin because the skin hasn't sloughed off and the skin can handle, needs to be have the anti-inflammatory effect, which gives a little bit less swelling, and a little bit less swelling gives pain relief. In the eye, doesn't do that. So that's a naughty thing to do, to put non-steroidals in the eye. It's just going to burn his eye. It's not going to do much. Stay away from that. Certainly don't put cortisone in his eye. Don't put antibiotics in the eye. Don't do that kind of thing. What you need to do is you need to switch off the alarm. You need to switch off that pain alarm for 24 hours for him. That's the bottom line. Switch off the alarm and keep it bandaged. Now, how do you switch off the alarm in an eye and keep it bandaged for 24 hours? That you have to practically work out for yourself how you're going to handle these patients. Remember, they're alpha males. They're guys that they're class 1 type A personalities. They're used to being the guy. Now you want to tell him to keep his eyes closed for 24 hours and not give him any medicine. That's crazy. So what you do is in the office, you give him analgesia in his eye, local anesthetic. You put drops in. Every 5 minutes, you put a local anesthetic in there for half an hour. In other words, you switch off that alarm for at least 2 hours. At least 2 hours, you've switched off the alarm. What a pleasure. He's going to like you because you've already taken his pain away and you've done your thing. Now you need another 22 hours. So you need to keep his eye bandaged. Now, the best way to bandage an eye is with the lid. Close the lid. How do you close the lid for some time? Is sleep. Sleep closes the lid for some time. Much better than pasting it closed, because you're going to fight that. The eye's going to move a lot. It's not a good idea. So you need to switch off the alarm as well systemically. So you need to give him a good, solid anesthesia. You need to give him pethidine if you have to. Go to the opiates if you have to. But give him really good pain relief. He needs pain relief. He doesn't need stuff in his eye. He's already got an exposed eye. So you need to give him analgesia, lots and lots of it. And you need to give him some local anesthesia, but in the office under your supervision. Don't be tempted to give it to him home. If you do, you've switched the alarm off and he's going to move his eye. He's going to go out tonight because he's feeling fine, and it's going to not heal, and you're going to end with a corneal ulcer. He's anyway a guy that doesn't wash his, or that works with dirty things, so there's always that chance that you could get a secondary infection. You get a corneal ulcer with because of the secondary infection, and you're in big trouble because you treated it wrong, especially if you gave him some steroids. Now you've given him some steroids, which also stops the wound healing, and he's with his grubby fingers rubbed his eye, and you're in trouble. All right. So basically, do as little as possible. Switch off the alarm with whatever you've got. Throw everything at it. Explain this to him and say that you need to go and fall asleep. So you can rather give him a sleeping tablet. Give him something to knock him out. These guys normally say, I'm not going to take any tablets, doc. Leave me alone. Then you say to him, okay, well, have yourself a nice double whatever you drink, a double brandy and Coke. Have a nice big meal and go to sleep. And phone them tomorrow and say you're not going to be at work tomorrow. You're only going to be there the next day, and try and sleep for as long as possible. Try and get through that 24-hour period as long as possible. So that's arc eyes in a nutshell. Don't put muck in his eye. The last thing you do, don't treat it like that, and don't give a analgesic home. You give the analgesic home, you've just switched off the alarm. That eyelid rubs the eye. He's going to rub his eye with his grubby fingers, and he's going to get a corneal ulcer, and you're going to be in massive trouble, which you caused. So don't do that. Primum non nocere. First do no harm. Huh? Right, so that's arc eyes in a nutshell. And of course, give him the appropriate speech about putting his visor on and this and that. But they'll all deny that they did it. I know for myself, I've also done a lot of welding. Yeah, there is certain times when you want to just arc a little bit and you get it in. So it's very difficult to really tell them not to do it. But you've got to give them the speech because they need to hear it. Right, so that's arc eyes. Then foreign bodies, we're going to move on to that. When we were speaking about arc eyes, I said that be careful that there could be a foreign body as well, because these guys normally work with grinders. So they're a supersonic, superheated iron filing shoots off and hits him in the eye. Even if they've got the protective spectacles, very often they don't have the protective. They never say that they don't have them, but and they get past and they go in. They can really get past those protective spectacles often. The point about those foreign bodies are they are supersonic and they are superheated. So a supersonic, superheated metal foreign body that enters onto your cornea burns right into the stroma of the cornea. So it goes through the epithelium into the stroma. The epithelium heals very quickly and actually covers it. Bang, covers it quite quickly. So very often these guys get a foreign body in their eye and they don't come immediately. In other words, they deny when the day they come to you with this painful eye and you see the grinder spot, or you don't see it yet, you're just doing a good subjective, is that they deny the fact that they used the grinder in the last 24 hours. It's sometimes much longer than that, 3-4 days before this thing gives pain. And the reason is it's burnt right inside, the epithelium closed over it. So the first couple of days doesn't feel so bad. And then suddenly, for no reason, this thing starts becoming painful. Wow. And it's got the scratching sensation, blah, 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 blah. At the end of the day, what happens is the salty tears actually rust that foreign body. It rusts it. And that iron oxide, the body doesn't like at all. The oxidated iron doesn't like it at all, and the inflammatory process goes. So the lesson there as well is don't be swayed by the denial of using a grinder or being the thing in the last 24 hours. It could still be, because it could be older than a couple of days. The second thing is that when you do treat it, you must remove it and remember that there is probably a rust ring sitting there that you can't see very well. So if you can't see very well and you don't have the appropriate magnification or the appropriate tools, don't think that you've helped the guy if you take a little black thing off of his eye. You've left the rust ring and he's just going to think you're a fool because you were supposed to have helped him. You've taken his money and he needs to go to someone else anyway. So be sure that you remove the rust ring. If you can't remove the rust ring, or if you're unsure, please send him to someone that can, because that's the way to treat the guy. Because the problem is, when you've taken off the foreign body, you've actually got a defect in your cornea, in effect. A defect in effect. There you go. Nice little bit of alliteration or assonance. What is that? So what you need to do is you need to treat him with a little bit of antibiotic. You need to treat him with some antibiotics. You can even give him a little bit of cortisone in the beginning, a cream or a drop, which will help for the inflammatory reaction, but make sure that you remove the rust ring. Very, very important. Right. That's foreign bodies. Remember, that's metal foreign bodies. The other foreign bodies that are very important to remember, if someone has been working in the garden and trimming his hedge and doing that sort of thing, and he gets a foreign body in his eye, remember that those foreign bodies can often carry in funguses, that they can get a fungus infection of a wood foreign body, especially thorns, that sort of thing. They've been cutting their hedges, they're cutting the roses, gets a foreign body in his eye. Be careful of removing it and just leaving it. And the guy complains. The thing to worry about there is fungus infections, and you need to cover him for that, or at least send him to someone with that in mind. All right, so wooden foreign bodies are a thing. The other foreign body that catches you out very often is people with birds in the house, or birds' aviaries. The birds normally break open the little seeds, and the husk remains behind, and it looks like a seed. And what they often do is they blow on the husks to get rid of them, to see how much seed there is, and they put new seeds in there. Those husks can fly up because you blow them and you're close to them, and go and sit on the eye. If they sit on the round side on the cornea, no problem. But if they sit with the open side on the cornea, they suck onto the cornea and initially have no problems. but they just chronically hurt that eye and chronically hurt that eye. So be very careful of people with aviaries. They tend to blow the seeds, and those seeds get in the eye and they catch you out. You say that you can't see anything, there's nothing there. Have a really good look, because there could just be a husk sitting there that's relatively inert, but in time does hurt the eye. You need to remove it. Right, corneal abrasion. Let's talk about that, especially the type of corneal abrasion that corneal abrasion is basically a stripping off of the superficial epithelial layer, very similar to arc eyes, but this is a traumatic stripping of the epithelial layer. Now, when you strip that, it could be a baby that reached out to a mother and just scratched on the eye. It's extremely painful, extremely irritating, and really a bad situation for the patient. There, a bandage contact lens would work very well. Similar treatment to arc eyes. Get them to close their eye, patch their eye, put a bit of antibiotic in there, give them massive analgesia, and follow them up and make sure that that corneal ulcer gets smaller, or the corneal abrasion gets smaller. Very often 24 hours and the corneal abrasion is better. Something that catches you out about corneal abrasions is chronic corneal abrasions that are caused by a massively dry eye. What happens is recurrent epithelial erosions. We call it recurrent epithelial erosions, and they normally happen in the middle of the night. Somebody goes to bed, that's normally an elderly lady. She has low estrogen, so she has dry eye. She hasn't been treating the dry eye properly, and she wakes up in the morning with this terribly, terribly painful eye, because the eyelid has actually stuck to the cornea, and as the eye moves, it tears off a tiny little piece of the epithelium. And erodes that epithelium away. But it's such a small little scar that by the time she gets to the doctor, you look and there's absolutely nothing wrong. Absolutely nothing wrong. The epithelium is fine. You put fluorescein in there, doesn't color, doesn't do anything. And you say, lady, yeah, I hear you, but, and they get branded as being people that hypochondriacs, and be careful, because it can be true that they get this recurrent epithelial erosion. It hurts in the eye when they wake up, and 2-3 hours later it's better. Be careful when you have that history of early morning, really, really painful. When you look, it's absolutely normal. Refer this patient. Make sure that their hormones are right. Make sure that their dry eye is being treated properly. Sometimes we have to even do more fancy stuff than that. Right, then how does glaucoma present? Glaucoma is a thief in the night. Most glaucomas are not painful. Most glaucomas are not painful. Glaucoma is not a painful disease. It's a thief in the night. That pressure goes up and up and up, especially open angle glaucoma, goes up and up and up, squeezes on the nerve, eats away at the side vision, You're getting tunnel vision, but it eats away slowly, so you don't even notice it. Doesn't take central vision away, and by the time it takes central vision away, you're in big trouble. So glaucoma, unfortunately, doesn't really present with pain and poor vision early. And that's why it's such a horrible, horrible, terrible disease that we need to flush out if we can with routine examinations. Some glaucomas do present acutely, and that is your intermittent angle closure glaucoma. In other words, the eye is fine, but it closes up the angle for some or other reason intermittently. And when it does close up the angle, the pressure goes up very quickly. Doesn't go slowly like in open angle glaucoma. It goes up very quickly. So if you have a quick rise in pressure, what happens is it squeezes that pressure through the endothelium and into the stroma, and the stroma gets swollen of the cornea, and they have poor vision. They have halos around, they have poor vision, trouble. There's the pressure causes so much pain that they even get nauseous from the pain. They can even have vertigo from the pain. So vertigo, nausea, red, painful eye that doesn't see well. Be careful of angle closure glaucoma, especially if there isn't any corneal problems or any discharges. It gives no discharge, and it gives no corneal reflex trouble. What it does is it has just a swollen cornea which is a little bit cobblestoney. So when you do shine a light on it, there isn't a perfect little reflex back. There's a little mottled reflex coming back, and painful, nauseous, can't handle this. That's angle closure glaucoma, intermittent angle closure glaucoma, and needs to be treated by an ophthalmologist. So refer them as quick as you can, but recognize them. But other glaucomas, unfortunately, creep up on you like a thief in the night, steal your vision without you knowing. Terrible disease. Okay, uveitis, the last one that we're going to cover. Uveitis is one of those. You know, as a registrar, you read a big fat book like this. There's a big fat book like this that's brought out by the American Academy. It's just a massive, it's just full of information, and the title is extremely ironic. It says, A Brief Introduction to Uveitis. And it's a big fat book like this that you have to wade through. So uveitis is really such a broad topic, and as a GP or as a registrar, the thing that gives it away normally is that it's intermittent. The type of uveitis is that you see, it's normally unilateral and it's normally intermittent. So he has pain. He has the look of glaucoma about him. He's got poor vision because of this inflammation in his eye. It's red, it's painful, and it comes and goes. It's just important to take his pressure in that time to make sure that it's not a glaucoma that you're dealing with. And of course, if it recurs, you need to do all the special investigations for autoimmune diseases. X-rays of the SI joint, X-rays to see if it's not an ankylosing spondylitis, rheumatoid factors, and all those things. Of course, a good history is very important here, and get the rheumatologists involved if it is a chronic uveitis. Remember, bilateral uveitis with mutton fat capies, that sort of thing. Those are more serious diseases that need to be investigated, and you need to try and treat the underlying cause. And of course, treat the eyes as well as you can with all their sequelae. But that's, I think, beyond the scope of these videos. Well, there we go. There's some really interesting red eye diseases that you hopefully will not be afraid of, and make good diagnoses. Remember, primum non nocere, first do no harm, make the diagnosis, give the appropriate medicine, and remember, less is more. The less you give and the more you diagnose, the better doctor you'll be. So join me in the next video where we're going to talk about refractive errors and all the interesting things around that. So join me then.